Welcome, everybody. Thank you so much for joining us today. My name is Rachel Schrader. I am Vice President of Clinical Care and Education at Parent Project Muscular Dystrophy, and we are thrilled to have you here today with a group of fantastic panelists talking about pulmonary management in Duchenne muscular dystrophy, especially this time of year when all of the viruses are running rampant, as is evidenced by my own congested voice, as you can hear. So I'm really excited to kind of go through this journey with you all in terms of pulmonary management at home, in the ER, and when you get admitted, and how to most effectively manage different stages and types of illnesses, and how to best advocate for ourselves and for our families. So essentially what we're going to do is we're going to walk through this journey together. We're going to hear from Dr. Dan Sheehan of University of Rochester on managing respiratory symptoms at home before we hear from Dr. Courtney Gushu, who's at Nationwide Children's and is going to talk about when to seek medical care. So when does it go from we can manage things at home to we need more help? And then from there, we'll hear from Dr. Andrew Sokolow of Vanderbilt, who's going to talk about how to navigate the ER, the ICU, the inpatient unit, how to advocate for our loved ones and navigate those really tricky situations. After that, we'll go ahead and pivot to an open Q&A session. So if you have questions during the talk, please use that chat function in the bottom of your screen, type your question in, and then during the second half of our time together, we'll work through as many of those questions as possible. So with this, I am going to go ahead and turn things over to Dr. Dan Sheehan.
Well, good afternoon, everybody. Let me turn this to slideshow. And as Rachel said, we are hearing so much in the news and we all are experiencing a big respiratory virus season. The three big guys are respiratory syncytial virus, influenza, and COVID, but also in the background in the community, there's also a number of other viruses that are out there that can also cause similar symptoms with it. RSV had its kind of big peak in mid-November, and cases are on the decline, but there are still a lot of cases out there filling up emergency rooms and filling in hospitals. And RSV typically hits hardest infants and toddlers because their airways are smaller, and RSV causes a lot of swelling inside the airways. So they make even smaller airways even smaller with it. In addition, older adults in their 60s, 70s can also be affected by respiratory syncytial virus. And the symptoms you get with it typically are fever, runny nose, cough, and in the infants, they have crackles, they have wheezes, and sometimes increased work of breathing. Influenza is now on the rise, and we haven't seen its peak yet. So definitely, if you have not gotten your influenza vaccine yet, I would recommend it for you as well as for your family members as well. And COVID has had a steady increase, but it's predicted that we're going to get some rise with COVID over the winter months as well. And so COVID and flu have very similar symptoms. In addition to fever, runny nose, cough, just like RSV, you can have chills, headache, muscle aches, fatigue, vomiting, diarrhea, as well as sore throat. So it's really often kind of challenging to figure out which virus that somebody has unless you do testing for it. So with any respiratory infection, there's ways that we all can manage them at home. I think one of the key things is really to stay well hydrated, because in order to clear mucus from our nose as well as from our airways, we need to have a moist body and moist mucus. And then there's certain medications that we can also consider. And I would encourage you to discuss with either your primary care, your neuromuscular, or your pulmonary team, which medications might be best for you. Tylenol is typically used for fever, but fever is not a bad thing. Fever is our body's way of fighting infections. And however, if somebody has a fever, they're not eating, they're not drinking, it is well worth it to try and bring down that fever. I just wanted to check the chat to see if somebody was trying to tell me something, but not. Nasal saline drops that we use for infants can also be used in older children. In addition, saline can also be given through the nebulizer to loosen secretions in either the nose or the airways. Cough medicines can be tried, and I think in general, the majority of cough medicines really don't work all that well. But it doesn't hurt to give say a 24 or 48 hour trial, 1 to 2 day trial of a cough medicine to see if it works for you. Something like Robitussin or dextromorphan. You got to be really careful these days because there's a lot of cocktails of cough medicines that have a number of different medicines, but you definitely want to avoid Sudafed within it. As far as cough suppressants go, cough is a good thing. It's actually coughing out the infection. But if it's interfering with sleep, a cough suppressant can also be tried. Mucinex can also be used to thin secretions. I personally haven't found it all that helpful, but if you've used it in the past and it's worked for you or somebody has suggested it, I think it's definitely worth a trial to try and thin thick secretions. But you should know whether it works for you within a day or two. And if you have a history of asthma, it's always worthwhile to try albuterol or Xopenex. These are two medicines that the only thing they do is relax the muscles down in the airways. However, a lot of cough comes from up here. And so often albuterol and Xopenex will not help with a cold that is really staying in the upper airway. And then I'll talk a little bit about antivirals in a second. There we go. So let me just make sure I hit the right one. Okay. So PPMD is a wonderful, wonderful resource to find out information as far as how to manage the flu, how to manage COVID. This is a site that I would encourage you to take a look at. It will talk to you about and guide you about influenza vaccines, symptoms, medical management, antivirals, when to seek care. And I also want to remind you all that who are on deflazacort or prednisone, that sometimes, depending on the dose that you're on, you may need stress steroids when you have a cold or a fever or a pneumonia. And there's a protocol that can be downloaded that you can look at as well as share with your healthcare providers on how to manage stress dose steroids if you need stress dose steroids with either a cold or a flu or a pneumonia. So who do you call and when do you call them? Well, your primary care is really great. Your primary care team is really great for general guidance with your symptoms. They can also sometimes get you in urgently or tell you where best to go for an urgent sick visit. They probably know best locally where you can be tested for influenza, RSV, and COVID. And sometimes that can be done in your office and their offices. And they can also prescribe antivirals for you as well. The neuromuscular team, they provide a critical role helping you decide about that corticosteroid stress dose. They can also prescribe antivirals. And you also want to let them know if you're going to the emergency room or if you're going to urgent care. As far as your pulmonary team, I would give them a call if you've got increased work of breathing. We'll talk about oxygen saturations if your oxygen saturation is less than 95%. If you're having wheezing or coughing fits, we have some tricks up our sleeve for those. And if you're going to the emergency room or the urgent care with the above symptoms, I would highly recommend that you give them a call and a heads up, and then encourage those ED or urgent care physicians or care providers to give the person on call a call. So as far as the antivirals go for influenza, you always want to try and start them within a couple days of symptoms. And really what we have out there now is really Tamiflu in the form of a pill or a liquid. It can be given as treatment for anybody older than 2 weeks of age, but also if somebody comes into the household with flu or lives in the household with flu, you can also do post-exposure prophylaxis. It's a different dose, and this is good for individuals greater than 3 months of age. These other two antivirals can be used, but it's typically going to be Tamiflu that's used. And a couple good resources as far as the treatment for the flu, as well as antivirals, can be found on the CDC as well as on the PPMD website. As far as antivirals for COVID, really it's the Paxlovid, and that's typically for individuals that are greater than 12 years of age. And one of the things with Paxlovid, there can be some drug interactions, so always want to check with your pharmacist. And then there's an online place to check as well. And then what's really helpful is that there's actually an online site where you can find out who has that supply of Paxlovid if you need it. As far as monoclonal antibodies, I think the gist of this writing here is that they're really not recommended at this point. This came out just at the end of November, that the current monoclonal antibodies are not effective with the COVID variants that are out there right now. So really, it's going to be that COVID antiviral that is going to be most useful. Antibiotics. Well, we talked about viruses, and typically viruses alone, you would never start an antibiotic with it. Looking back to the 2018 DMD care considerations, we recommended that you start antibiotics with an acute respiratory illness if you have 3 of the 5 following signs, they being a fever, elevated white blood cell count, or an inflammatory marker called C-reactive protein, sputum production, a pulmonary infiltrate on chest radiograph, or respiratory distress or hypoxemia. So that's the reference that can be shared. Again, it's, you're starting with an you're starting with a virus. The question is there a bacterial infection that's possibly occurring on top of that? And that's really keeping this in mind, but talking with your pulmonologist and talking with the team, either in the ER or in the hospital. So this is a slide of when individuals with Duchenne will have breathing muscle weakness that requires equipment to either support a weak cough, weak breathing while asleep, or weak breathing while awake. And everybody with Duchenne is different and will need support equipment proactively at different times. Some boys will need a cough assist, in their early teens, some in their later teens, but usually by about 25 years of age, all men with Duchenne will have a cough assist to help them with their cough. Very similar with weak breathing with asleep. And then those individuals that will need assistance with weak breathing awake, that typically may start to occur in the 20s, but typically by the early 30s is when somebody will need support. And so we're going to kind of switch gears to those individuals that have a weak cough and have a cough assist at home. So at home, what we typically recommend is that when you have an upper or lower respiratory infection, that you use a cough assist every 4 hours or as needed. And these are 2 of the versions that are out there, the old style and then the new style. Both work very, very well. And also, I do recommend that you try and have a pulse oximeter at home, because it gives you an idea of whether there's extra secretions in the airways that need to come out. And so what is a pulse oximeter? Well, if you break it down, what it does is it measures how covered your hemoglobin is with oxygen. In your blood, you've got white cells, you've got red cells, and the red cells, you've got hemoglobin, and it's the hemoglobin that carries oxygen to the tissue. And it measures it in your arterial blood. So it's actually, as it's looking at your finger or passing signals through your finger, it's looking for a pulse. It's looking for that arterial blood that's taking oxygen to your tissue. And you'll hear it called pulse ox, you'll hear it called oxygen saturation, you'll hear it called O2 sat, you'll hear it called hemoglobin saturation, and you'll hear it called stats, and probably many other things as well. And so, it's really come down in price over time. And some of us may still have some money on our flexible spending accounts. And so a good pulse ox is probably somewhere between $30 and $70. Amazon has an FSA site, a link on as well, and they have over 75. I think one of the key things to look for is that there is some signal that tells you that that the pulse ox is picking up the pulse, that it's seeing a nice beat that's going along with the beat of the heart. And if it is, then you can believe what the number is. And it's really only when you have a nice, good signal can you believe the pulse ox. So lastly, this is a handout that we've used a number of years while I was in Buffalo, as well as here, as far as how to handle colds. This first paragraph just talks about, when we all have a cold, we tend to be a little bit weaker. More recently, I've added this section here. There are times when we just need a little bit more oomph to our cough. And there's something called breath stacking, where you take a big breath in as far as you can go, and then take another breath on top of it. And that gets additional air in that allows you to take a cough in a way that you might not need the cough assist. And so again, it's taking the biggest breath in possible, a little bit of a pause, another breath again, and then trying to cough to remove mucus. If you have a cough assist, we do recommend it every 4 hours. And, some individuals have a vest at home. A therapy vest is that vest that you might have seen that kind of shakes the chest and moves the mucus. Typically, that was designed for patients with cystic fibrosis with very thick mucus. The majority of patients with muscular dystrophy do not need a vest, but some individuals may have it. If you have that, you can go cough assist, vest, and then cough assist. The other thing I would encourage you to do is that when you're done with your cough assist treatment, is you don't want to leave yourself sucked down with the cough assist. You want to try and end with an inspiratory breath. And so I would encourage you to talk with your either your pulmonologist or your respiratory therapy or your home care as far as how do I get that nice big breath at the very end of a cough assist treatment in order to leave my lungs inflated. And then on the bottom of the page, it talks about if your oxygen saturation is less than 95%, use your cough assist and then recheck. If your oxygen saturation doesn't increase to 95% or higher after the cough assist, that's a good time to call your pulmonologist or your neurologist. And if you end up going to the emergency room, the last thing I want to really, really remind you is bring your equipment with you. Bring your cough assist with you. Bring your BiPAP with you. Because of the hospitals are so full, there's actually a shortage in a lot of hospitals as far as cough assist and as far as BiPAP as well. So definitely travel with your cough assist and travel with your BiPAP. And with that, I'll switch over to Dr. Gushu.
Thank you so much, Dr. Sheehan. That was really helpful. I see we've got some great questions coming in. As a reminder, plug those questions into the chat and then we'll get to those at the end. Next, we're going to hear from Dr. Courtney Gushu about when to seek medical care. So you've been managing at home. What do you do next? Things aren't getting better. What are those next steps and how to know when to take those next steps? All right.
Thank you. I'm glad everyone was able to log in and listen today. And thanks, Dr. Sheehan. I agree with a lot of those points you made, really important points. And I think I'm going to touch on some of those as well. So we'll get started here. Again, so we've already talked about kind of what to do at home, and I'll go into some details on when is it time to go to the hospital or go to the ER or urgent care, really knowing on kind of the edge step there on what we can do at home. So first, again, I'll touch on some things we've already gone over and talk about some of the upper respiratory symptoms. So this can come with a lot of the colds and viruses going around. So you see sneezing and stuffy nose, runny nose. And you may sort of see some of these things because our upper airway is particularly prone to becoming affected by some of these viruses. So to continue on talking about just some of the things that we can sort of manage like a regular cold. And we've just talked about some ways to manage that. It's sort of, I think I call it more of like our yellow light, our kind of take a pause and try and increase our therapies at home for some of these upper respiratory symptoms. Really, a lot of what we'll see is trying to, again, manage the stuff that I like how you put it, Dr. Sheehan, up here and not have it really settle down into our lungs or develop into a pneumonia or more serious issues. And with this, again, it may be more of just kind of the sneezy, runny nose type of stuff. You may have a little bit more cough when you have colds and upper respiratory infections, because some of it is going to drip down the back of the upper airway, as you can see in that picture there. So you might need more cough assist and suction just to sort of clear it from getting out of this airway and sort of tickling those cough receptors and causing more trouble there. When you have some of this upper respiratory issue, you may have maybe a reduced appetite if there's some postnasal drip that can cause a little bit of nausea, or you may not have as much of a taste or a smell if you're really congested with some of these illnesses. So it's okay if you're not really eating lots of solid foods, but really wanting to encourage good hydration. So making sure you're keeping an eye on things like how much you're drinking, how much you're peeing, making sure your urine doesn't look like it's dark to ensure adequate hydration. And again, the ability to loosen those secretions, and really reasons that we'll start to look at, maybe I need to get seen, but not quite yet. I put fever on here as sort of, again, in our sort of yellow light medium zone, because sometimes you can absolutely manage a fever at home. And sometimes it's not a real sign of something serious. So if it's coming along with a cold, and it's something that we can treat at home. But I'll talk a little bit more about when that becomes more serious and when you need to come into the ER. And I think about this when things start to shift into more of lower respiratory tract issues. And so some of the main things we think about in something like virus season or the winter season is something turning into pneumonia, like you can see on the picture on the far left here in an X-ray. So there's a pneumonia evident here, and that's when we have sort of filling of the actual airspace that's responsible for gas exchange, oxygen in, carbon dioxide out. You can also have some more lower respiratory issues if you've developed something like a pleural effusion. So that's the middle picture here in the cartoon. There's a fluid that builds up around the outside of the lung, but still within the chest wall space. And if there's a lot of fluid there, it can actually sort of compress on part of your lung, not allowing it to expand fully. And so you're not able to get as much good gas exchange when some of the lung is compressed from an effusion there. And I've included a cartoon image here just to, again, sort of reflect on some of the important muscles of breathing that we know are affected in muscular dystrophy. So you can see the little muscles in between all the ribs, the intercostal muscles, and then the big dome-shaped muscle, the diaphragm, that separates the chest from the abdomen, really. And I think about these muscles in particular in muscular dystrophy. We think about like your bicep muscle flexes and goes like this. When I think about the diaphragm flexing, it's going to pull down that bottom part of your chest, so your chest can get bigger and your lungs can open up really nicely, get a nice big breath in. Again, oxygen in, carbon dioxide out. So if our muscles are weaker at baseline, we're not going to get as much of that diaphragm excursion. So sometimes we need to breathe faster in order to get the same amount of gas exchange. Again, oxygen in, carbon dioxide out. So if we pair an already weakened muscle plus something like either a pneumonia or a pleural effusion, and you're really getting less effective area for ventilation or for that gas exchange. And that can lead you to have either an increased work of breathing or an increased respiratory rate, which are some signs that it's time to go in and be seen. So this is when we get into sort of like that red light or more emergency room evaluation kind of zone. The first three things I'll point out. So like I was explaining, increased respiratory rate, sometimes increased heart rate. And then other signs of increased work of breathing are telltale signs that there might be something more serious going on, or kind of in the lower half or the lower respiratory system, like a pneumonia or an effusion that needs more monitoring and treatment. The other thing that's important to point out with these sort of three sets of signs and symptoms are that they can also occur or come to start happening if you have something with your heart isn't pumping quite as strong and are having some issues with circulation and our blood flow. So that's why it's hard to sort of triage some of these things by phone sometimes. And we do want you to be seen in person with increased respiratory rate, heart rate, or work of breathing. One of the other things that I think is important to point out, and you may have noticed that sometimes it's harder to really tell an increased work of breathing if you have some muscle weakness at baseline. So it might not show as much in your chest wall or abdominal wall muscles kind of squeezing harder. It may be more of looking at your nostrils flaring, trying to get more breaths in, or somewhat of your head moving a little bit more when you're taking breaths as other signs of labored breathing. Sometimes if you have BiPAP just for nighttime use, sometimes we'll have, in talking with your pulmonologist, in some cases it's appropriate to spend a little bit more time on BiPAP if you're needing a rest or you're not feeling great and you want to rest a little bit more, or you're needing to sleep during the day. But if you come to a point when you're sick and you're just not able to spend time off of the BiPAP machine, that's a big indicator to us that it's time to come into the emergency department, because sometimes we need to actually dial in higher BiPAP settings or even think about other kinds of ventilation. So like a negative pressure or cuirass type of ventilator we'll sometimes use, or sometimes even an endotracheal tube for invasive ventilation if we can't get good ventilation from a BiPAP machine alone. So that's a big indicator that we would need you to come on into the hospital to be seen, okay? Other indicators that we're working harder to breathe, or there might be something more serious going on, is an inability to talk in full sentences. So if you think about how much breath goes in to talking, if you feel like you need to stop, right, like that to get more breaths in between words, it can also be an indicator that you're not getting enough breath in. A couple more pieces that are not specifically respiratory related, but other signs of serious illness that we would want you to be seen for are if it's harder to get you to wake up, if you are awake and you're not making sense, or if you're not either making a normal amount of urine or your urine is really dark, all indicators that there's something more serious going on and we want to see you here in the hospital. I put fever on this slide as well because there are some cases where fever can be a more serious problem. So two pieces I'll point out are, one is, just as Dr. Sheehan mentioned before, if you're on a higher dose of steroids and you have a degree of adrenal insufficiency, or your body is not making enough of its own steroid, it's really important to be in touch with your care team about a fever to see if you need a dose that's stress dose steroids. And lastly, if you have any sort of like implantable device, so I think about a port or any central access. So some people are getting IV infusions for some of the therapies we use nowadays. Really important, if you have a fever, you have to go be seen, because one of the things that can happen and can present with a fever is a bloodstream infection, which can make you sick really fast. And we need to make sure we get blood cultures and start antibiotics until we prove that there's not a bloodstream infection in those cases. So those are all really important reasons to come into the emergency room. Another thing that I would point out is, if you're having respiratory distress and you're needing to seek care for some of these reasons that we just talked about, I think going to the emergency room is generally going to be your best bet. If you have something that's more like runny nose, stuffy nose, you feel like you need to get tested for the flu or COVID, or you're concerned for something else, ear infection, strep, then something more like an urgent care might be appropriate. And the reason being, the emergency rooms are going to have things generally like more respiratory therapists available if somebody needed to go on BiPAP who's not usually on it, or if it was really severe and we needed something like intubation, we'd have more of a controlled setting where we can do a higher level of support than an urgent care. Next, again, this is sort of what we've talked about a couple times already, but if you're doing all of your usual therapies and you know how you respond to them, you're still symptomatic despite already having increased your cough assist or spent more time on your BiPAP, you're not responding to additional therapies, again, that's when we want to see you. And you generally know how you guys feel or how your children are feeling after you give some of these treatments. So when in doubt, we are happy to see you, and you can always call your care team. Next, we already touched on a couple of these, but I'll talk about them as well. Specific conditions that we would want to see you for. You don't necessarily have to come into the emergency room if you're suspicious for flu or COVID, but the reasons that we may have you seen is if we need to be tested or if you think you need specific therapies for these. So like we talked about already, I won't go into details, but flu, we know there's not really tons of home tests for flu, so you might need to go to the primary care doc or the urgent care to be treated, or you can be treated if you've been exposed to the flu. And COVID, I won't go into all these details again. We know there's COVID tests at home. Some of the treatment options available, I put with an asterisk here, because it'll vary by center and availability of these medications. So there are some IV therapies. Remdesivir is used in some cases, which is an IV medicine. We already talked about how monoclonal antibodies are not being used right now because of the recent reported effectiveness. And Paxlovid, like was already talked about. So important to note that not all of these medicines are available everywhere, and you might not qualify for them based on your age and your size. And if you do qualify for them, it's really important to make sure you talk with your team and a pharmacist to make sure you're not having drug-drug interactions like with Paxlovid, particularly with our medication eplerenone that we use often in muscular dystrophy. So for some closing thoughts, again, if you're not quite sure, feel free to call your home center because we can help you work through it. And if you are going to come in, I second what we've already talked about, is bring all of your things, because you don't know if you're going to be waiting for a long time or if there's going to be people or equipment to do things like cough assist and BiPAP while you're waiting. And of course, if you're rapidly worsening or in severe distress, call 911 to get there quickly. So with that, I'm going to stop sharing my screen and turn it over to Dr. Sokolow.
Awesome. Thank you so much, Dr. Gusher. I think that was super insightful, and I know that I learned a lot. I really love that you talked about going to the ER versus when to go to the urgent care, because different venues are going to be able to offer different types of treatments. So keep those questions coming in. Looks like we've got lots of really great ones that we'll dig into just as soon as we hear from Dr. Sokolow.
Thank you guys for having me. Good afternoon or good morning, depending where you all are in the country. I'm Dr. Andrew Sokolow, and as stated, I'm from the center down here in Nashville, Tennessee. And so I get to talk a little bit about, if we end up in an emergency department, if we end up in a hospital setting, what kind to expect, and how we can, as care teams, as caregivers, parents, loved ones, advocate for our boys and young men with Duchenne's. So biggest objectives to take home from at least my part of this is really that knowledge is power. A lot of us can feel very overwhelmed, even if we're health trained professionals in high stress situations, in emergency departments, during the hospitalization. And it takes a high degree of comfort, I think, with what's going on to speak up. And so even if you're not comfortable speaking up, please do know that having this information will hopefully empower you a little bit to, if you feel a little hesitant, to say, hey, can we chat about this? Let's talk about what's going on. I'm not comfortable, or what's happening doesn't seem what I've been told to be working. Please listen to me, what I have to say about the care of my loved one. And just kind of overarching, what to expect if you're coming in for an elective admission. I know we're in respiratory season, but elective things still happen, or things that are not emergent that might find us in the hospital. But things are a little bit different because the hospital settings overall are experiencing high viral load. What happens if I'm in the ER, and what if it's a really unplanned or unexpected admission? So first off, be prepared. It's a good rule for all of us. We all have different centers do different things as far as how this is presented, but I think we would all agree that having an updated list of all medications and doses of the medications that we're taking at home, whether they be on a regular basis or in emergency situations, especially with our stress dose steroids, is going to be incredibly helpful. If possible, a lot of our patients here love those little USB emergency bracelets that they can have a lot of their information plugged in on. Other patients who are at my level of technical savvy still carry things on paper, but there's different ways to keep this information. Having good information as far as what your most recent lung function was at your most recent Duchenne's or pulmonary visit, and echo data if possible, what kind of gives the people in the emergency room setting or the hospital setting some more information to better care for your loved one. And that also goes for what our settings are on our CPAP, BiPAP ventilators, as well as cough assist devices. If we do find ourselves for any of these reasons in the hospital, having our own equipment, you'll hear a lot of the same messages over and over again from the three of us. Hopefully things are correct. But sometimes if we've passed through an ER, passed through an urgent care, sometimes people who may not normally be trained in these home devices may try to change settings, try to think they're helping, and may make unfortunate changes to your settings. And having your baseline settings can be really helpful for your medical team when you arrive. Keeping all needed contact numbers and contact methods for your DMD center and teammates can be really, really helpful as well. And we'll talk a little bit about post forms and living wills. No one likes to talk about it, but I'm going to do it if we're in those situations. So elective admissions, this is the easy one. We're coming in, we're having that skin tag removed, or we're having a wound closed, in an elective fashion. These things still happen during respiratory season, but as you probably gathered from the topic of this conversation, there are a lot of viruses going around right now, and these are not just impacting our Duchenne's patients, our other neuromuscular patients, other patients with other complex medical conditions, and just normal pediatric patients are finding their ways to the hospitals, and the hospitals are very, very full. And so it's important to know that, if you don't feel like the teams are all aware of what's happening with your loved one, that make sure that they are communicating with your DMD center. Again, you may need to bring your home equipment, and I always encourage my patients to bring their home equipment because typically we're most used to the equipment that we have at home, and a BiPAP device that the hospital may employ may be very different than the BiPAP devices we have at home. I'll tell you, a lot of times our patients at home get the newest and fanciest machines, which make our machines in the hospital seem very antiquated. And they are lamenting not bringing their home quiet, soft machine or equipment, or the interface that may not be as comfortable. Like, I love the nasal pillows I get at home for my BiPAP. This one's not comfortable. I don't want to wear it. It may not be the most ideal situation when we're recovering from surgery or having something elective done in the hospital. Again, I cannot stress enough, that Dr. Sheehan did and Dr. Fish did as well, make sure your vaccines are up to date. Flu vaccine, your PCV23 if appropriate, COVID vaccines, especially now with the fact that you've heard mentioned a couple times, the current monoclonal antibodies are not being very helpful in treating COVID. The current bivalent vaccines do seem to be helping a significant amount. Get vaccinated. Because one thing I can always guarantee about hospitals is they love to attract sick people. I put signs out all the time trying to get healthy people to show up. It just never happens. Hospitals attract sick people. And so even if you're coming in for something elective and don't have any viral symptoms, you may end up with them when you leave. And so anything you can do to protect yourself is going to be helpful. To that point, if we're in for something elective, it's supposed to be a really short admission. And we have lots of, it always takes a village. A lot of people want to come visit, wish you well. As you can see from this way, there are non-in-person ways to give your support to your loved ones. And so especially during viral season, if you're in for something elective, don't have visitors come marching through the hospital to come visit you. It's just not worth the risk of you getting sick. If you're coming in for something surgical, and again, hopefully these are being done at your DMD center, but that's not always the case. What you may have to do some prep work ahead of time with your DMD team, getting things like repeat echocardiograms, EKGs, or PFTs before surgery can be really, really informative to your anesthesia friends who are going to make sure that your loved one stays safe in the operating room. Make sure that your anesthesia team is well aware of the sedation risks that our boys and young men with Duchenne's carry with them, that not all medications that they would use routinely for any other surgery may not be appropriate for our Duchenne's boys. Hospital guidelines will vary depending on where you are, but a lot of our patients, even if they're able to be extubated or have the breathing tube removed in the operating suite, may still require ICU level stay afterwards, just for more close monitoring. So just be aware of that when you're coming into the hospital, even for an elective procedure that you might find yourself in the intensive care unit. That's not always bad, especially on the pediatric side. The intensive care unit has much different connotations than it does for our adult colleagues. But don't be surprised that occurs. And then, for a lot of procedures that are done in the operating suite, especially for our boys and young men with neuromuscular diseases, they do require some intubation or breathing tube placed to help them support their breathing during the surgical procedure. And so depending on where our baseline lung function is, it may take a little bit to get that breathing tube back out. And so the institution that you're having these procedures done should have in place a DMD appropriate extubation protocol, because the extubation of our Duchenne's patients is going to be very different than someone who doesn't have a neuromuscular disease. This time of year, as has been alluded to, you may find yourself in an emergency room. You may find yourself, you've implemented all the things that Dr. Sheehan talked about to try and manage things at home. Things got from the yellow zone to the red zone, Dr. Kushi was showing. And now we're like, okay, I need help. We're not at a good place. Sometimes we're able to transport by car. But oftentimes these things can sneak up. Okay, it happens in the middle of the night. All of a sudden the van's not working, something's happening. You can't get to the hospital without some help from our EMS colleagues. So 911, we heard that already. But while EMS is arriving, depending on where you live, I practice in Middle Tennessee, and a lot of our families are in much more rural areas. Tennessee is, a lot of our state is very sparsely populated, and it may take some time for EMS to arrive. And oftentimes when EMS does arrive, or if the first responders are, a police officer, or the, engine number 2 shows up, and they may not have the same degree of support that EMS would have, or even you have at home. Okay, so if your loved one is someone who is on nocturnal ventilation with BiPAP and they're awake but struggling, put them on their BiPAP while EMS is en route, because that may provide you a little bit extra support, a little bit extra time to keep things from spiraling out of control before EMS can arrive. Okay. The other thing to keep in mind about EMS, especially, again, this is influenced a lot by my practice, I know, but depending on where you are in the country, you may not go directly to your Duchenne center location when EMS picks you up. If you live, 200 miles from your Duchenne center, the ambulance is not going to drive 200 miles. They're going to stop at the nearest facility. And a lot of our families get a little worried about that. But honestly, if you're in that kind of shape, we want you to be seen by trained physicians as soon as possible. Even if they don't have the same experience with Duchenne's, we can always get you stabilized there with their help and then get you transferred if we have to. But again, because they may not be aware, having your contact numbers for your Duchenne center is going to be incredibly important. And this is where the advocacy comes in. Insist that they are called. I know this is, we're in this high stress situation, and we're just ridden in the back of an ambulance with our loved one. We're in a strange emergency department. We don't know any of these providers. Don't be afraid to call for help. Okay, and that's why your numbers are going to be so important. Bring your medication list. In these emergencies, it's not always the first thought to grab our cough assist, grab our vent, grab our BiPAP. If it's something that you kind of prepared for mentally ahead of time, it's always helpful to grab those things, because depending on where you're at, they may not have the same degree of support that you even have at home. And I know it's kind of shocking to a lot of families. Like, we went to our local ER, they had no idea what a cough assist was. It happens. Bring it with you. Once you're in the ER or the emergency department, depending on your breathing status, your respiratory status, you may be on your BiPAP, you may not. But one of the first things that EMS typically does, or the ER typically does, is slap you on some oxygen. Okay? Oxygen is great, makes us feel better. The saturations on our pulse ox starts going up. But for our patients with Duchenne's or other neuromuscular weaknesses, it's not enough often to support us adequately, because it helps get the oxygen up. It's not helping us get rid of the carbon dioxide, and it doesn't tell us if we're ventilating, if we're moving air well enough once we're on that extra oxygen. And so the ER should be checking other things, looking for carbon dioxide. This is often done with a blood sampling, looking for something called a blood gas, where they can actually measure the amount of carbon dioxide that's still in our blood. Okay. And if they haven't done that, ask for it. You may get a chest x-ray, looking for those pneumonias. Depending on the situation, you may even need a CT scan. And I mentioned that because, a lot of our boys, especially with, progressing scoliosis and discomfort in certain positions, this raises a lot of anxiety, having to be in an uncomfortable platform going through a scan. I encourage you, though, CT scans are quick. That little bit of discomfort is going to be well worth it if the clinical situation indicates. Let them get it done. Expect some blood work, oftentimes an EKG or an electrocardiogram, those little stickers on your chest to look for your heart rate and rhythm, as well as an echocardiogram will likely be done. And depending on where you find yourself, they may not be comfortable with the Duchenne's diagnosis in the current situation. And once you're stabilized, you may be moving again to a larger center or your DMD center. When that happens, if it's not, seen in the ER, everything's okay, you can go home. That usually leads us to the unplanned admission and what to kind of expect next. And this is kind of the tough one. This is one I was struggling with a little bit putting these slides together, in that, it's trying to explain the unexpected is incredibly difficult, because there's a lot of different reasons that our patients and loved ones with Duchenne's may end up in the hospital. These are kind of some of the more frequent ones that we see. We may see an acute change in our cardiac or respiratory function, and sometimes they can be challenging to pull apart. Is this a heart issue? Is this a lung issue? As a pulmonologist, the things I worry about most are things like these viral illnesses, flu, COVID, the ones that are getting a lot of press right now. But I'm hoping this is more of a universal talk, in that it could be adenovirus. It could be, even things like RSV, which we typically think of being a virus that really impacts babies. We're seeing a really bad strain right now in Middle Tennessee, and that's still leading some of our older patients with neuromuscular weakness to find themselves in the hospital. So there's a lot of different causes for that. For the viral etiologies, oftentimes it's just it's supportive care, keeping our patients well while that virus runs its course, unless we do things like some of the antivirals and other care that we've already talked about for COVID. These respiratory illnesses, increased work of breathing, can lead to other things, pneumonias, aspirations, where we get some stomach contents or things that don't belong into our lungs, which can make this a little bit more complicated. The heart may be having arrhythmias secondary to the stresses that we're seeing. We'll sometimes see our patients in the hospital after falls or traumas, and the workup for those are a little bit different. We worry about things like these fat emboli, where parts of, when especially our long bones are broken, some of that marrow and fat can leak into the bloodstream and get kind of caught in the blood vessels of the lungs, or in the brain, and cause some neurological and respiratory complications. And these may be hard to pull apart. And so you will probably see a lot of testing going on to kind of pull these different reasons apart to get you a good diagnosis. And then from that, the treatment will ensue. So it's hard to anticipate all these, but a lot of these have some common aspects. The common aspects are, be ready for some increased therapy. You may be used to only doing your BiPAP at night, but you might be needing some positive pressure 24/7, or for more hours than not during the day. The cough assist device will probably be used much more frequently, and the settings might need to be adjusted. Again, Dr. Sheehan mentioned the vest physiotherapy. Again, we don't typically use these, but again, there are situations where these might be helpful during certain types of infections or certain types of instances, especially if we're not being able to be as cooperative with some of the other therapies that we're doing. Oftentimes, when in doubt, we'll start antibiotics, because some of these issues, whether it be viral or bacterial pneumonia, may be hard to tease apart. And then it's always a risk benefit for us as healthcare providers. Oftentimes, the risk of an antibiotic in a critical situation is much, much lower than the risk of not giving it. And so don't be surprised if, we think it's viral, but we're going to cover with antibiotics anyway. We are well aware that viruses are not covered by antibiotics, but sometimes we just can't be 100% sure, and we're going to err on the side of caution. I think one of the things, I know it's really hard for a lot of our boys and young men, is, oftentimes they're hard blood sticks to begin with, secondary to our body structure, our muscle strength, some of our contractures, if we have them. Blood sticks are never a favorite thing. And unfortunately, when we're in the hospital, they may be frequent. And if we're in a situation where we're in an intensive care unit, they may talk to you about the placement of a central venous line. Pretty much these are things like PICC lines, peripherally inserted central catheters. They're just like an IV, but they go a little bit deeper into a bigger vessel. They're often a good way that we can draw blood without having to be stuck time and time again. They provide really good central access if we need things like fluid resuscitation or antibiotics. And they really are not that more uncomfortable than an IV itself. And so those things may be brought up to your attention. And then I think too, especially if you're finding yourself in an intensive care unit, I know this is a very sensitive and hard topic to talk about, but oftentimes families will be approached by people that they don't know are not the normal care providers about what are your decisions about intubation or other life-saving measures. And that's a little bit I know it's not everyone's favorite topic, because it's not my favorite topic to talk about, but it's incredibly important because, sometimes emergencies don't go the way we want them to. Things like talking about with your loved one with Duchenne's, would you want a breathing tube in place? Again, this is tougher for some of our younger patients, but as we get into adolescence and early adulthood, believe me, they've thought about it. These things, they're all on the, I shouldn't say all, most are on the blogs and on the different sites and social media, and these things are talked about. And so they probably know a lot more than we give them credit for, even as healthcare providers. And we should have these conversations, because whether it be living will, end of life decisions, or just something as simple as, hey, we think you have a virus, we think you're going to need a little bit more support. This seems recoverable. Would you be okay if we have a breathing tube in? And if we are unable to get that out, what are your thoughts on tracheostomy? These are important conversations to have when we're not critically ill. And the reason I'm going to encourage everyone to have those conversations early is it's much easier to have that conversation when things are calm and things are not emergent, rather than we're in the ICU and we're up against a wall and we have to make this decision now, which direction you want to go. If you've had those conversations with family, with your support team, they can help provide those guidance and that kind of that framework to kind of have these conversations. Because even very young patients who are having more advanced cardiac or lung disease will be they are always remarkably. It's always remarkable to me how much more perception of that and much more willingness there to have those conversations than we are as care providers. So with that, I think I just managed under my time. I'll make sure we have time for questions. That's my part of the presentation.
Awesome. Thank you so much, Dr. Sokolow. I think that this has been a really helpful overview of just kind of, from the very beginning management stages of what do you do when you start with that tickle in the throat all the way through, some of the more severe sort of options and treatments and things that we need to go through. So we have a ton of questions. We'll probably go a couple of minutes over if that's okay with everybody, so that we can get through as many of these questions as possible. But let's talk a little bit about commonly used medications at home. So I think Dr. Sheehan, maybe you can take this first one. We had a question about Tylenol 3, and then another question about managing or preventing postnasal drip while sleeping. So I think that kind of wraps into a singular conversation around OTC meds or meds that you might ask your doctor for to have on hand at home. Could you talk about what some of your favorite medications are to have on hand?
Yeah. So Tylenol number 3 is acetaminophen, Tylenol plus codeine. And so it's something that you need to get prescribed to you. It can help with cough, but it can also cause drowsiness, lightheadedness, dizziness, as well as constipation. So it's not something I would give to somebody before going to bed. Some people will rash with it as well. So it's something that I would, if you're going to try it under the guidance of your physician, I would try it early in the day and as a lower dose with it. But codeine can be helpful with cough. As far as postnasal drip, I think one of the key things is to really try and get everything out your nose before you lay down at night. And that may be, a saline rinse, that may be a saline neb, that may be a shower, and then, blow everything out that you can. There are some individuals that like Benadryl or Zyrtec as kind of an antihistamine, which can be helpful. You're going to hear me say it again. You can try it for 1 or 2 days. If it helps, great. If it doesn't, Dr. Sokolow, Dr. Gushu, do you have any thoughts on other things for postnasal drip?
I agree with those thoughts. If there's, in some cases, again, I would talk with your specific doctor about this. If you have just like copious runny stuff, sometimes, a day of Afrin or so, but I don't do that without talking to a doctor. You can have some rebound effects from that if you're using it for too long. So I agree with all of your other thoughts and talking with your doctors. Sometimes if it's more kind of like stuffy, sometimes a nasal steroid can be beneficial, but it's not really going to stop stuff from dripping down.
Great, that's super helpful. And one of the things that we'll be sure to link when we post the recap of this online is our safe and unsafe medications list, which includes both prescribed and over-the-counter safe and unsafe medications, which is a really helpful reference just to have on hand, particularly during this time of year when there are lots of medications in my own home pharmacy, if you will, and I'm sure that everybody on the phone can relate. So another medication question, let's talk about how this relates to stress dosing. So I've got a sick kid at home. He is being managed at home. We're doing okay. At what point do we need to start thinking about incorporating a stress dose for steroids? Dr. Gushu, do you want to start?
Yeah, so one of the things that we think about is if you are having a febrile illness, that's often a high stress state on your body, and you will often need to use stress dose steroids in that case. Another time is if you take daily steroids and you're unable, so whether you're having lots of vomiting or you can't keep anything down or you can't tolerate these enteral medicines, whether it's through the mouth or through a G or a J tube, those are some of the big times where I think it's important to talk to your team about stress dose. Now, most times we have a stress dose steroid available by mouth, which is a higher dose, but in some cases there's actually other forms if you can't tolerate an oral or an enteral medication, like a subcutaneous or injectable form. But again, certainly reaching out to your team based on how much steroid you get and how suppressed your own cortisol system may be.
Awesome. Dr. Sheehan, Dr. Sokolow, any additional thoughts there?
I just want to stress too that you should never feel like you're doing this by yourself, right? And again, every situation might be different. And I know for our center, and I'm sure most centers across the country, when in doubt, just call us. Because again, it may be some fine details like I'm not really that sick, not having fever, but then we find out that you've been vomiting for 3 days. I mean, again, it's hard to put a cap on when it is appropriate because every situation is going to have a lot of different nuance to it. So I think if you're in doubt, call.
Yeah. And I would just add, again, on the PPMD site, there is the protocol that I would say download and share with either your endocrinologist or your team, because it does talk about, okay, what dose do we need to start and what would we consider that stress dose to be? So it's very helpful.
Absolutely. We'll be sure to link that too. For anybody who's not familiar with it, that's that PJ Nickoloff steroid protocol. And it goes over what your baseline dose is, what adrenal suppression is and what it means, and then when would you stress dose and at what level, because that can be dependent upon how sick or not sick you might be. All right, so this next one, I think we will field to Dr. Sokolow because we're talking about more invasive interventions. And so the question is, how do you know if your airways have collapsed? And when does one go for a tracheostomy? It's pretty complex.
I'll start with the first part, so the airway collapse. I mean, airway collapse is not a common thing, but I think it's a term that a lot of different patients present with. And I think in ER settings, in urgent care settings, even in primary care settings, an airway collapse might mean different things. It may mean that you have mucus plug and that on an x-ray you can't see the airways anymore. It may mean that you have something called atelectasis, which is something that we see frequently in a lot of different lung diseases. And pretty much that's again, it's a mucus plug, but our lungs are designed to absorb gases. Obviously, things like oxygen are the ones we think about most, but the pulmonary tissue will absorb other gases as well. And if you have a mucus plug, all of the gas behind it will eventually get absorbed slowly, and that airway looks kind of collapsed. And oftentimes people are told, well, their lung is collapsed. That's very different than as a pulmonologist. That usually, when we say lung is collapsed, that means like there's a pneumothorax, there's air outside the lung in the chest wall that doesn't belong there. And unfortunately, I think this is where what an airway collapse can be very, very different. What happens too with our so if it's not a mucus plug, if it's that kind of stuff, it's stuff like increased airway clearance, increased cough assist, sometimes inhaled medications to help open those airways up, which is very different than the second question, which is the tracheostomy. That's tough. Tracheostomy is and I want to see what Dr. Sheehan and Dr. Gucci want to add to this too, but that's a very personal decision. I have had that conversation in the last 6 months with at least 5 of our boys, and only one of them has even given it thought to go to tracheostomy. Tracheostomy is, in case people don't know, it's an artificial airway that goes into your neck, into your trachea or your windpipe, and is used as in our neuromuscular patients as a way to provide a stable airway for something like a ventilator. Some patients don't think that's an acceptable way of life, and others think this is perfectly fine with me. And so that it ends up being a very, very personal choice. But usually what happens is, as we see our vital capacity, as our respiratory strength continues to diminish, and we're seeing those symptoms like carbon dioxide building up in our blood even when we're awake. It may be inability to clear our secretions, well, even with things like cough assist, or increased need for daytime ventilation, like a SIP ventilator or a BiPAP. That's kind of when we think about, which option would be best served for you, having a stable airway with a mechanical ventilator, or do what we're doing with the non-invasive means.
Dr. Sheehan, Dr. Gusher, anything you want to add?
I agree with Dr. Sokolov. It's a choice that works for some families. Beforehand, there is the nighttime ventilation, and then during the day, there are individuals with Duchenne that wear the nasal mask or nasal prongs throughout the day. There's also the SIP ventilation. So there's other things before that occurs, but it's good to have the conversation if somebody's lung function is declining to kind of talk about that. So it's not kind of an emergent thing to do.
Thank you, Dr. Sheehan. All right, let's switch gears a little bit and talk about Paxlovid, because I know, at least in my own community, COVID is going around really bad right now, and I think we're probably seeing that in a lot of our communities. And a lot of our guys are on eplerenone, and the two don't mix. So if you have a patient who needs Paxlovid and is on eplerenone at baseline, what do you recommend? Do we just discontinue the eplerenone for a few days? Do we switch to spironolactone? What are you generally doing at your centers to manage that drug-drug interaction? Dr. Gusher, you want to start?
Yes. So the issue with these two meds together is that Paxlovid increases the concentrations of eplerenone in your blood based on how these are both processed by the body. So I think one of the most important things is to talk with your center and pharmacy so they are aware of your other medication lists, and know, we've had a lot of conversations with, if somebody needs to use both the Paxlovid because of COVID. We will generally, on Pulmonary, I'm talking to my pharmacist and my cardiology team to ensure that we're safe to be off of eplerenone for these 5 days, and generally are, looking at our risks and benefits and knowing that we're wanting to treat this COVID. I haven't had anyone who's said don't use or don't drop the eplerenone while you're on that brief course of medication. But my recommendation is to talk with Pulmonary and cardiology about these two things.
And is it generally that you can go, on Monday, I'm taking eplerenone, Tuesday, I will not take it. I'll take my 5 days of Paxlovid, and then the very next day I can get back on it. I don't have to like a washout or anything like that. Okay, cool.
Yeah, we're not washing out. I mean, even if you've had your morning dose and you test positive, we're starting Paxlovid, and we'll just monitor, off the medication. Some of our kids who are a little bit more fluid sensitive with their cardiac status, we might add a secondary diuretic just to help bridge us. But most of our boys and young men have done fine off there for 5 days.
Perfect. Very good. All right. This next one, I think this is a really good question, and it's one that we end up talking a lot about on the PPMD team, and that's how to advocate for your child when perhaps he's in a situation where he's in the care of a provider who maybe doesn't know him or doesn't know Duchenne as well, and might not be super willing to engage with other team members. So do you have any tips or tricks on how to get maybe that community hospital, that smaller hospital, that not your home center hospital doctor to talk to your primary Duchenne team? Any words of wisdom there?
I would have to, what I would say is probably to call your primary Duchenne team, either your neurologist or your pulmonologist, and have them call and reach out. If somebody has an ego problem, it's very doubtful that they're going to make that first call. But if you can have your neurologist or your pulmonologist give a call, I think that's the best bet. The other thing is I would look for somebody on that team that may be the respiratory therapist, it may be a resident, it may be a medical student, it may be somebody that can help advocate with it. In addition, most hospitals do have a patient family advocate that can also be reached out to as well.
That's great advice, Dr. Sheehan. I think it's really easy to forget that a patient advocate is a person that is there and is on your team and you can ask to speak with if you're not making the progress that you want where you are, depending on what your scenario is. Another resource that we have available on our website, and we've been trying to circulate it on social media, all of our certified care centers have phone lists that we've made available. So it's your clinic phone number for during business hours, it's your after hours numbers, and then your physician to physician connect phone number as well. So we'll be sure to share that and link it when we push this out, in the next couple of days so that you all have a chance to see that. You can keep that, print it out, put it in your Duchenne binder if you have one, store it on your phone. That way, if you find yourself in a situation where you're like, I don't know who to call, you've got that and you can reference it. Okay, this is a really good question. So, can too much straight oxygen be bad during surgery because of CO2? Who wants to talk about oxygen versus pressurized support?
So I think I would maybe address this in two ways, and you guys jump into if I'm not doing it justice. I think one, just addressing the oxygen by itself alone related to carbon dioxide, as Dr. Sokolow had mentioned, it can certainly be problematic if you're only getting oxygen and you need that ventilatory support too, right? Because you want, again, oxygen in, carbon dioxide out, just by giving oxygen alone. If you're, in some cases, if you're used to having either a little bit lower oxygen or you're just getting simply oxygen and not positive pressure to help get carbon dioxide out, your body may think like, I'm doing just fine and I don't need to breathe quite as much. And then you can retain some more carbon dioxide. As it relates to surgery, generally when someone is under sedation for surgery, they are generally being ventilated as well. So you're actually getting the breaths are being taken for you, or they're being supported or assisted. So you should also be getting those additional breaths. If oxygen is needed on top of that ventilatory support, whether it's while you're sedated for anesthesia or you're on a ventilator or BiPAP, that's more of a reasonable standpoint, because the key is that you're getting both oxygenation and ventilation done. So Dr. Sheehan or Sokolow, jump in if there's something to add with that too.
Perfect.
Awesome. So I recognize that there are still a handful of questions in our chat that we weren't able to get to, but we're at about 10 past the hour. And so I want to be mindful of everybody's time, both our speakers and everybody that's listening in. So I think at this point, what we'll do is start to wrap things up. What we will do is work with our amazing speakers here to address the rest of these questions, fold them into our post-webinar recap materials that we push out next week so that you're still getting answers to your questions, and make sure that we're giving you all of the resources that you need to be able to care for your family and your loved ones at home. With that,
would you mind if I answer that? There's one last question that I also do COVID research, so I can't not touch it.
Okay.
The last question that just came in was about the monoclonals, and it's a great question. COVID has changed, right? The original strains that we saw are back in 2020 in the US are not the same strains we're seeing now. And the antibodies that were developed were on those original strains. So as a lot of viruses changed, even our own antibodies that we make ourselves don't work as well. And so if you had COVID back in 2020, don't think you still have protection now against these current strains. And so that's going to be really important. So there are other treatments. Paxlovid, we talked about a lot. I want to keep beating that horse, but I just wanted to address that monoclonal thing. And they may come back. So just because the CDC right now says they're not helping, doesn't mean that current strains, there are future strains that they won't be. So always ask your center. Sorry, I had to get that out there.
No, I love that. I think it's really timely. RSV didn't used to be something that we had such a big conversation about, and now we're having this huge conversation about RSV. COVID looked like something, almost 3 years ago. Now it looks different, and it might look different again in the future. So these are all really, really great points. Thank you to our speakers for joining us and letting us pick your brains and understand how to navigate this really difficult time of year when it comes to all of the bugs that are floating around. As I mentioned, there will be a recording of today's webinar available on our website, social media, and YouTube channels, as well as a recap blog with the Q&A and all of this good stuff so that you've got it available all winter long, along with some of our favorite resources like our safe and unsafe meds list, our care checklists, the PJ Nicholas steroid protocol, clinic phone numbers, all of that good stuff so that you're empowered and equipped to manage these issues as they come up this winter. And with that, I am going to say thank you again to my speakers and have a great day, everybody. We'll go ahead and conclude our recording.
Thanks, everyone.